everybody. I'm here with Dr. Berger, Dr. Sultan, and of course Dr. Veith. My name is Ido Weinberg, and we're here to talk about PCSK-9 inhibitors, statins, and lipids. First I'd like to ask everybody a question. It's basically for everybody. My question is, is this a big issue with patients nowadays? Are patients coming to you and talking to you about LDL reducing medications and specifically PCSK-9 inhibitors?
I'll go first. I don't think they're doing it enough.
It's a major problem. Patients come to me, basically they don't want to start it for primary prevention. They have to get well informed in order to see the options before starting any medication. And I think that it's incumbent on us as physicians to educate our patient that a tablet per day will never keep the doctor away.
I think a lot of these patients are at high risk for having a cardiovascular event. And I think when you tell them that we have lifestyle changes, we have therapies that can actually help prevent both heart and limb events, they get very excited and they want to know more.
All right, so building on that, Dr. Berger, again, a question for everybody here. Before we dive into the details, I want to talk about prevention. Dr. Waxman earlier today in one of the sessions mentioned prevention is key. I want to know your opinion. Is prevention reasonably practical in today's world to really avoid these heart and limb events? So maybe we'll go the other way this time.
Sure. So I think prevention is a major focus in taking care of these patients. I think unfortunately we wait until the cat has gotten out of the bag, and I think we can do a lot. I think patients can do a lot. I think a lot of patients rely on pills and tablets, and I think when you tell them that there are things they can do, they can eat healthier, they can do more exercise, they can stop smoking, and that will have a more profound effect at preventing these really bad vascular events. So I think it's extraordinarily important, and I'm a huge advocate.
Dr. Sultan, is it reasonable? Can it be done?
Definitely, primary prevention is the cornerstone for cardiovascular management. However, still you cannot give something that causes more harm than benefit for the patient. You cannot get a healthy woman, give her a tablet, and within 2 years she's diabetic. Or get a healthy man, give him a tablet, and within 3 years he's depressive, he had to change his hip, and he has total amnesia. We have to be very careful what we do and what we prescribe for our patient for primary prevention. And remember, none of the trials that done for primary prevention showed any benefit in cardiovascular mortality or morbidity with statin for primary prevention.
Dr. Veith.
Yeah, I think it's not even arguable that if you can prevent a catastrophic event like a stroke, a heart attack, or death, it's a lot better than anything else. And I'm a great advocate of medical therapy. I agree completely with Jeff. These arteriopaths have disease everywhere, and the only way you can address it is medically. The interventional treatment of a given lesion is a good thing when it's justified, but all these patients have to be on intensive medical management.
All right, diving right in now, I'd like to talk about the latest AHA guidelines that just came out last week for cholesterol management. And what they said, basically, they said high-intensity statin, on top of that, sometimes ezetimibe, on top of that for the high-risk patients, such as the polyarterial patients you've mentioned, add a PCSK-9 inhibitor. Do you think that's the way we're going? Is this the way, adding medications? Do you think patients will comply? Do you think us as physicians will be able to do that?
I think we should do that. I think lowering LDL is critical, and I think lowering it by a substantial amount is important. And if you can't lower it just with a statin, I am a great believer that that should be done. I may have some disagreement with some of my colleagues, but I think the guidelines are right on target, and I do look at the LDL levels.
Dr. Sultan, the PCSK-9 inhibitors were compared to statins. We know your opinion about statins. You were also vocal about it just a minute ago. Do you think there is any theoretical room for these new medications to benefit some patients?
That's a very, very important way to look at the current situation. PCSK9s came on the way that the more you lower the LDL, the more the patient will benefit. However, there is no correlation between lowering the LDL and decreasing the cardiovascular mortality from the 4-year trial. That's the first thing. The second, which is very important, all-cause mortality have increased by 4% for the patient on PCSK-9, so it did not cut cardiovascular mortality. And in fact, it's have other major problems that we have to look at it. So to get something that's been given injectable, that's very expensive, despite that the prices have been dropped for a marketing reason, and then tell me that it will change the way, it doesn't make sense, because LDL, whatever you're going to drop it, didn't correlate with any advantage in decreasing cardiovascular morbidity and mortality.
Dr. V.
Yeah, with all due respect, I disagree, because the Odyssey trial clearly showed that the lower the LDL, the better. And it's hard to argue, even though there may be side effects and costs, if you can live better and live longer, why not? So for me, it's a no-brainer.
Dr. Berger, what is the mainstream opinion nowadays among the cardiovascular community when it comes to LDL reduction?
So I think that there is a host of studies that have demonstrated pretty convincingly, in my opinion, that lower LDL cholesterol patients do better. I would suggest, and I would argue to my patients, or not argue, actually explain to them the importance that when you give a patient certain drugs, forget about what happens to their LDL cholesterol, because at the end of the day, that's a number. But what I tell patients is that when you give them a certain drug, be it a statin or a PCSK-9 inhibitor, they have fewer heart attacks. I think that is undoubtable, undebatable. They have fewer strokes. They have fewer composites of cardiovascular events, and they have fewer limb events. So when you tell a patient you can have less of these really bad events, to me, patients get very excited, because unfortunately they've had many of these events before you see them.
So I'm going to let our viewers know that off camera, Dr. Waxman just arrived, and he's a proponent of preventive medicine. I'd like to ask everybody, maybe as a closing question, if you had unlimited funds, what would you do in order to improve the cardiovascular health of our patients?
I would support the intensive medical management with drugs, lifestyle management, and I think the newer drugs and the evidence is overwhelming that it makes a difference. I personally believe that my LDL, I'm better off when my LDL is lower, and I think to convince our patients of that is what we should do, and then facilitate that lowering.
Dr. Sultan, in a positive way, I know what you would not do, but what would you do to improve the cardiovascular health of your patients?
I look for the reason for the cardiovascular problems, and I'd like to manipulate the inflammatory cascade that causes the cardiovascular problem and start concentrating on it and manipulating it. We cannot put all of our eggs in one basket. It's not one thing that causes the problem, it's multitude of factors that we need to look at, we need to improve on it in order to get a better outcome for our patients.
Dr. Berger, where's your bang for your buck?
Sure, so I think the future lies in the world of prevention. I think we have to do a much better job at preventing the first cardiovascular event. That means exercising regularly. That means eating healthy foods. That means not smoking. I think after you get over that threshold, I have a very, very short line until I would begin something like a statin drug. But I think we have to remember that lifestyle comes first.
So you've heard it here, there's controversy versus mainstream, and prevention is likely key when it comes to cardiovascular disease. Thank you very much, everybody. We have Dr. Waxman, Dr. Sultan, and Dr. Berger here. We're going to talk a little bit about primary prevention and the role of the vascular specialist in primary prevention of cardiovascular disease and limb outcomes also. So Dr. Waxman is a true expert and a proponent of prevention. What is the role of the vascular specialist as opposed to the primary care specialist? How can the vascular specialist influence their patient for better primary prevention of cardiovascular morbidity and mortality?
Yeah, so I think we have to start early. We have to start with the younger patients. It's not that easy because they usually don't come to the vascular specialist, so maybe we have to reach out to them. But the awareness to the disease has to start at an early age, and I would start actually with the children of our patients, because most of them, genetics is very strong. We know they're going to have the disease. So through our patients, we have to detect who are coming for a secondary prevention. We have to detect their children, and I think start with them. But I think, in my view, prevention today should be the number one. I mean, this is a much larger market. We are going to treat the secondary prevention, but the primary is the key.
Dr. Sultan.
I'm taking a proactive way in this. I go to primary schools and give a lecture, a very simple way to kids. Tell them that their enemy is sugar, the sweets, the problem, and how to go further. Educating the young, when they grow up, it will change everything. At the same time, we have a very concentrated effort for a lifeguard program where we do carotid duplexes and femoral artery duplex to see the carotid intimal sickness and start advising the patient on lifestyle changes. We try to avoid medication in this very healthy population in order to recruit them back. It's all about epigenetics and the way to upregulate the good gene and to try to switch off all the keys to downregulate all the bad genes.
Dr. Berger, in your center, you have a dedicated service for primary prevention. Tell us a little bit about that.
Sure. So we believe very strongly in prevention of cardiovascular disease, as do most. At our university, when a patient comes into the medical center, a member of the prevention program will go see them and talk with them about how do I prevent heart disease? How do I prevent limb disease? I clearly agree with my colleagues. Education is at the forefront. And I think a lot of times patients wait until they get a prescription drug. So we tell them that they can change things if they change around their lifestyle. And I think that's probably the number one place to go.
All right, my last question to the panel is as follows. We all know compliance is an issue. If you had to choose two medicines that are the best for primary prevention in our sort of sick population, what would be those two medicines with the highest impact?
I would say exercise and diet, but obviously if you need to know your cholesterol. I think that if you have a high cholesterol, you have to take care of that. It's very hard to get 200 LDL just by diet and exercise to a lower level, and I think we have to emphasize on the low LDL. I mean, the studies are very strongly suggest that low LDL can reduce events. So what is available there? I mean, statins, Zetia, and for those who do not respond, they'll have to take PCSK-9.
Dr. Sultan, your two most interventions that you will choose.
I check homocysteine for all my patients, and hyperhomocystinemia is the most commonest cause for advancement of peripheral vascular disease in the young and in the middle age. And it's very important for them to know that it's very simple with vitamin B, folic acid, or even eating a lot of greens could do that. And the second thing is I'm very, very generous by prescribing metformin in borderline diabetics, because the reason for that, lower the sugar level is the cornerstone in maintaining a normal endothelium function in the patient and prevent any more progression to the atherosclerosis is the point of no return.
Dr. Berger, your two strongest interventions for primary prevention.
So the first one would be easy for me, and that would be a statin. And I would not think so much about their LDL cholesterol. I would think that these drugs are really effective at preventing a first heart attack, stroke, or death. And when I tell that to patients, they get very excited. The second would be a lot more difficult, and I think there is some suggestion maybe towards aspirin in certain high-risk individuals, maybe metformin in other, but I think statins are by far the number one choice.
Yeah, but the aspirin actually has been controversial. There were multiple studies recently that showed that
Especially for primary
prevention. So I would table the aspirin. I really don't think we have good medication. We still need to find them. So there is a need actually to find something. But I do believe that when you look on the LDL and it's reflecting your atheroma volume at some point, we probably going to start earlier to look on those indices. I mean, it's not going to be, and I think the guidelines that made a big step forward in that direction. So it's not, you don't have to have an event right now to start statins. So there's a lot to continue to develop.
The problem with the guidelines, they never tell you what you have to do. And I think that one of the major things for any patient, whatever primary prevention, you have to be happy, less stress, be continent. If you have a nagging girlfriend or a nagging boyfriend, dump them, because life is very short and stress is crazy.
Well, you've heard it here. Stress is harmful. Difficult to find consensus about two interventions, but primary prevention is likely key. You've heard everything from diet, exercise, addressing homocysteine, and statin therapy. Thank you very much, everybody.
Pleasure.
Thank you.